So what we've got here is we have a situation where we've got a patient with a bridge right at the front. And the big thing here, we have a very, very high and revealing lip line or smile line. Everything that we're going to be doing over here is going to be on display, right? So we just need to be super careful both in the evaluation of this case and also in what our kind of solution is going to be. The teeth were really, really wobbly. I'm talking, if he sneezed hard enough, this bridge would pop out, okay? He's not been able to eat. And the big issue here is he's had a bridge, it's not working. He's now exploring implant options. We've got a retracted view here, and you can see that whoever's designed this bridge, they've really, really tried to get something across here. Got a much longer tooth, you know, if you compare it to the other side, and that's again because we've lost volume at the top. This bridge was fractured, and they've used something here to try and splint it together. But like I said, this whole thing was moving, you know, from an aesthetic perspective, obviously not great. You can also see how the volume has been lost in that area, okay? And as I was saying, yeah, aesthetically not great, agreed. But most importantly, functionally, Stephen he can't function. And that's a major, major issue because obviously you should be able to eat in a comfortable way, should be able to go out without having the fear or feeling that at any given point his bridge can fall out. Obviously embarrassing, not ideal. So all these thoughts are going through the guy. So step number one, let's go in and now radiographically and assess how much bone we've got to play with. And this is one of those cases where the bone was really, really minimal. I've just got a slice of his 3D bone scan. This is directly at the front of his mouth is an outline of the bone, okay? So that's how thick the bone is, which is very, very little. I think when we measured this, it was 2, maybe 3. And you know, you may have heard me speak before, your average implant diameter is between maybe 3.5, 4 millimeters. You need a couple of mils on each side, so you can't work with this. And it was very similar all the way across the front 5 or where the front 5 or 6 teeth would be. So we spoke to Stephen and we said, look, listen, we think that we can help you here, but the way to do this is we need to grow some bone. So we carried out and we performed a double block graft, one anteriorly on the top right and one on the top left, obviously after removing those teeth that were infected and getting rid of any infection there. And the main purpose of the block graft is to create an environment into which implants can be placed in the future. So we went from that thickness to that thickness, okay? So you can see over here, this x-ray is taken probably about 8 or 9 months after we got Stephen in, we did the surgery. It takes a bit of time. This is a pin that holds the graft in place, and you can see the volume, it's just significantly thicker, right? So on the day of surgery, this pin is removed. The way that we now manage the placement of the implant, because obviously it's a block, yeah, it's been there for 8 months, 9 months. But when we're putting the implants in, we're not trying to go in and achieve a high torque, which is what we would normally go. By torque, I mean the tightness of the implant. We're not trying to do that. We just want to put the implant in and let it heal for another 3 or 4 months. We don't want to put too much stress on it, but we managed to grow the bone. And this way it was in the interim. Stephen was wearing a denture, but it was designed in a way that it put no pressure on the anterior because we didn't want to disturb the graft. So implants went in, but you can see where the implants have been placed, and that was the bridge that was designed. Okay, that was permanently fitted in, and again the lab work's been done by our laboratory. You can see that looking from that image, this is pink porcelain or pink composite that's been put in. I'm going to show you quite a good image of this in a second, retracted. So you can see that although the implant went in and we created bone and widened and thickened the bony plate, we still had to go in and put some composite material to replicate and mimic the gum. So this is a close-up. The lab came in, they matched the teeth, of course. Here's the outline of the bridge. You can see how closely that's been blended in. It's very difficult to tell, and it's been designed in a way where Stephen can get in under with floss, with a like a water pick, to make sure that he can access and clean the implants. Absolutely crucial. A lot of the times these bridges can be designed in a way that they don't allow the patient to clean them, and what's going to happen is that it's going to stay there for a couple of years. The implants are going to get infected because they're not being cleaned, and you're back to square one. But you're not square one, you're back to -1, because now there's even less bone than there was at the beginning, and we've got to carry out these big procedures. I think the whole treatment plan here took probably in the region of 12, maybe 15 months. So if you've been told that you don't have enough bone, the bone's not thick enough, there are surgical techniques, well documented, well practiced, that we can sort that out. We can grow the bone in those areas, make it thick enough, and give you predictable implants to give you a smile and your bite back. And yeah, I think Steve's over the moon. He said he was going to send me a picture when he was at the steakhouse. I'm still waiting for that picture, but when he does, I'll post it. Okay, thanks guys.